Welcome to the Pacific Research Institute Next Round podcast. I'm Tim Anaya, PRI's Vice President of Marketing and Communications, and your podcast co-host. This week, we're pleased to welcome back our colleague, Dr. Wayne Winegarden. Wayne is a PRI Senior Fellow in Business and Economics and the Director of PRI's Center for Medical Economics and Innovation. And Wayne has just released an important new brief, which, if you're interested, you can download a copy of at medecon.org, that sets up a problem that you may not be noticing. And that's the push by government healthcare bureaucrats at both the state level and the federal level away from healthcare competition and toward taking away choices from patients. And one of the key examples that he highlights in his brief is a state-run program. It's called the CAL-AIM program, and it's a program that serves those who are duly eligible for Medicare and Medi-Cal, Medicaid nationally. And the program's aim is to keep people out of nursing homes and such. But a new update to the program, starting at the first of the year, is going to take away choices from patients. And so Wayne and I talk about the consequences, this push by government away from competition and what it means for the quality and availability of care, the costs that patients and taxpayers have to bear, and what it will mean for health outcomes for patients. So stay tuned. After this break, I invite you to join me and Dr. Wayne Winegarden as we discuss this important new brief. Thanks so much for listening. We'll get back to our terrific interview in just a moment, but first, PRI's YouTube channel is must watch. By visiting youtube.com/Pacific Research 1, that's the number 1, you can watch webinars, videos, and other original content, including our new Free City Center video tours and interviews. You can watch as PRI's Wayne Winegarden tours Dignity Moves, a San Francisco nonprofit that is reimagining scalable solutions to homelessness with founder and CEO Elizabeth Funk. And you can check out Stephen Greenhut's tour of a proposed new city in rural Solano County that has generated significant interest and intrigue. You can even listen to previous episodes of Next Round Podcast. So visit PRI's YouTube channel today at youtube.com/Pacific Research 1, that's the number 1, and click the subscribe button to receive notifications about our latest content as soon as it's posted. Well, Wayne, we're so pleased to have you back on Next Round to discuss an important new brief that our Center for Medical Economics and Innovation recently released. And for our listeners who are interested in reading a copy and following along at home, you can go to the center's website, which is medecon.org, and you can download a copy of the brief. As we dive into this discussion, let's maybe start with a 30,000-foot view question on, kind of why is this principle that we talk about a lot of having competition in choice in healthcare, why is that so important to people's healthcare?
Well, Tim, this is such an important question, and I'm really glad we're able to talk about this today. And I think it's important because while this issue is specifically for kind of what they call the dual eligible population, patients who qualify for both Medicare and Medicaid, meaning they're older and they have less income. But and this is a problem for this group today, but the issue is broader than this, because we have, like you said, from that 30,000-foot perspective, we're having to defend what really should be obvious to people. Right? That when you have more competition, when you have more people supplying something and more organizations supplying something, you get better outcome. Right? And this is like the introduction to the paper. It's hard to imagine somebody saying, I can get you better car prices if only you turn over all, automobile dealerships over to the government. And, that just sounds ridiculous to say it, but that's the perspective that pervades healthcare. And focusing on this issue, I think, is important because we're seeing more and more the application of this idea that with single payer, with reduced narrow networks, and all of these things of restricting choice, that we're somehow going to come up with better healthcare. And wherever you look, it's actually reversed, right? Where we have healthy competition in healthcare, whether it's delivery of care healthcare or health insurance. And it's always important to differentiate those two. But where you see more competition, you see better outcomes and quality. You see better quality as well. And that's important because quality is always in the eye of the beholder in many instances. And with choices, you get a more robust environment where providers can serve kind of different needs and different choices. And so, I think one of the great ironies we're seeing in healthcare today is that on the science, we're continuing to move towards more personalized medicine. And yet in the delivery of care, we're going more towards like a Soviet style sclerotic delivery mechanism. And those two just don't mix.
So, Wayne, as you write in the paper, we continue to have this push in states like California, and you see kind of the more extreme voices in Congress like Bernie Sanders and an Alexandria Ocasio-Cortez. They're continuing to push for single-payer, government-run healthcare with no private sector healthcare choices. And we're seeing that states that are promoting single payer, they're using Medicare and really Medi-Cal or Medicaid outside of California to push forward that vision into reality. So before we get into this California example that you highlight in the paper and really, I think is such a good example of this dilemma, walk us through this movement toward fewer choices and more consolidation and how that will hurt patients.
Yeah, and this is really, it's a great question because we're just going deeper into what we were just talking about, right? The typical justification that advocates of socialized medicine, we call it democratic socialism more broadly, right, is that, and they make this about any argument, and the basis for what they're saying is the epitome of static thinking. And it fails to understand the creative and innovative process and how it's innovation and creativity that generates the outcomes we want to see. So in their minds, what they take, again, that static look. So they'll look at the profits and they'll say, oh, that's an unnecessary cost. If we scratch that out, we can drop prices and we'll have cheaper healthcare. And then you'll say, okay, and economies of scale, right? The idea that with greater efficiencies, we'll have, we'll reduce bureaucratic costs. And with greater efficiencies, we'll be able to, as a sole purchaser, we'll be able to negotiate better. And that way, this socialized medicine or single payer schemes are going to save even more money by being better negotiated. And the problem with that way of thinking is that these savings, they work in theory, right? They work in an ivory tower or on the chalkboard, but it's not how things work in practice. It's not how, I don't like this term very much, but I'll use it, the real world works. And in reality, right, actual savings emerge because of innovations, both large and small, that people working in the field figure out, sometimes it's a little tweak to some sort of administration that all of a sudden you can save, half hour a day, which ends up saving a lot of money. Or it's a big way of redesigning how healthcare is delivered. And you can create all sorts of savings because of that innovative process. And that's the way we're going to get better healthcare. By listening to patients and by incentivizing providers to come up with these new, innovative, personalized ways of delivering care. When you have a single payer system, it thwarts innovation. It's these huge bureaucracies. They really subscribe to that the old Henry Ford motto, right? You can have the car in any color you want so long as it's black. I mean that's what we're talking about with single payer. I think I'd end with saying that, right? When you have a large single payer or narrow network of all these kind of huge nationalized or socialized healthcare, by definition of being that big bureaucracy, everything is geared towards serving the average patient. And if you want good healthcare, and if you want to save money, you need to serve the individual patient, not the average patient. And it's that need when you have such a huge bureaucracy to serve the average, which is why socialized or single payer healthcare is always destined to provide inadequate care and really you save money by denying care, which is not the objective of what we're trying to do.
So you also in the paper you pierce the bubble that's been blown by advocates of less competition that you can save patients and taxpayers if you just have one choice, or two choices, fewer choices than we have now. Walk us through what the data shows on that front. How does less competition impact healthcare costs?
Yeah, and there's been lots of studies out there doing doing this. Right? When you look at those, you find that there's a strong relationship between greater competition and lower prices. That applies to hospitals, it applies to doctors, it applies to insurance. And that was something that we talk about a good deal in the paper because we're trying to kind of demonstrate that we want competition in all of these areas. So there was one study that it was a lit review. So it's kind of nice because they've gone through all the literature for us, right? So, and they noted they were looking at it with respect to competition in the hospital space. And they found that when you go through the literature, that when you have greater competition, it leads to substantial price increases. And they said it was typically on the average of 20 or 30% lower in those areas with robust competition compared to areas with less competition. And they saw in some studies it was as high as 65%. So when you have more hospital systems, which is troubling because we're seeing a lot of mergers and acquisitions and big hospital systems gobbling up the little ones. But when you have more competition, hospital costs come down. There was a study in JAMA, the Journal of American Medical Association, that was looking at primary care physicians. And they were saying that, if you had more competition, right, you could see costs, I say if you have less competition, you would see costs 11% higher for primary care physicians. There was another one that looked at health insurance, again, the exact same result. But what was really interesting about the health insurers is that the study found that when you had less competition, you had lower payments to providers, which you can perhaps argue that that's what you want. But the problem is you also saw higher premiums for beneficiaries. So you really see those monopoly rents being sucked up there because both providers are paid less when there's less insurance competition and beneficiaries are paying more. And that's just not what we want to encourage. And that's why we need kind of more robust competition in health insurance.
We'll get back to Next Round in just a moment, but first, are you getting PRI's regular email updates? If not, go to pacificresearch.org and click the sign up button at the top of the page to get the facts you need to fight back delivered every week to your inbox. Every week, PRI sends you what you need to know about what's going on in Washington, D.C. and Sacramento, and gives you the free market ideas needed to save our state and our nation. By going to pacificresearch.org and clicking the sign up button, you can sign up to have Policy Alert, our weekly roundup of all the best ideas from PRI scholars delivered to your inbox. Or you can sign up for event updates so you're the first to know when PRI is coming to your community with great events. So sign up now at pacificresearch.org and click the sign up button at the top of the page to get PRI's content delivered to your inbox each week. So let's now turn to the California problem that you highlight in the study. So as you write, this bias against competition from state healthcare bureaucrats really is encouraging bad policy, as we're seeing here. So tell us about the Cal AIM program, which serves dual eligible Medicare and Medi-Cal enrollees, and how the program's forthcoming changes are going to take away choice from patients.
Yeah. So, and this is, links right to kind of the insurance kind of examples we were just talking about. So just, we mentioned this earlier, but just when we're talking about the dual eligible beneficiaries, we're talking about Californians who are over 65 and that are also lower income. And so that's what we're dual eligible for Medicare and Medicaid, which we call Medi-Cal in California. Now, there's about 1.7 million people who qualify for that broader Medi-Cal, for the broader dual eligible. And this is, one, these are very vulnerable people. They often have complex medical needs. And you're also now at the intersection of two bureaucracies. So it can be very complicated in terms of, both for the beneficiary, but also for the bureaucracy itself. And so CalAIM has come up with a good idea. They're trying to stand up these Medi plans, which are a type of a Medicare Advantage, right? So Medicare Advantage is, in Medicare, we have traditional Medicare, and then you have Medicare Advantage, where instead of getting kind of the fee-for-service model, you actually get private Medicare will cover private insurance. It's all the commercials we see at this time of year trying to get people to enroll. That's Medicare Advantage, and actually about half of Medicare beneficiaries are in a Medicare Advantage plan. Well, these are specialized Medicare Advantage plans that California is standing up to serve this specific population, and that concept is a very important concept. And it's great that we're trying to do that. However, it's always what comes after however is what's important. important. The restrictions that they've set up are basically blocking out competition from counties. So you have current kind of plans who are serving, this population that aren't being allowed to expand into these kind of these Medi plans. And so what you have is within each county in California, you have kind of specific insurers, public-private or public option, as well as often, not always, one or two competitors, but there's lots of other competitors that are out there that people are being blocked from because of the rules and regulations and all these other factors. And so what you're essentially doing is you're limiting the competitive environment for these plans. And that's going to start in 2026 so that seniors are going to be blocked out from potential plans, reducing that competition. And, as all the data has shown, the expectation about this is that we're going to see, a growing cost and declining quality in these plans if we don't get this right and don't bring in more competition.
Now, of course, we're talking about the most vulnerable population here that would be negatively impacted by all of these changes. So can you give us some more insight on how some of these communities would be impacted, such as people have chronic conditions or those who may have a limited English proficiency? How specifically would these people be most negatively affected by these changes?
Well, you're being negatively impacted because your choice in plans are narrower, which means, again, you go back to Henry Ford. You can have any car you want in any color you want as long as it's black, and that, when it comes to healthcare, becomes problematic, and especially when you're talking about, like you were saying, the vulnerable population, these dual eligibles. You need to be able to serve their individual needs. They need more options because people, different plans are going to have different things that they emphasize, which are going to be appropriate for some, but there's going to be other arrangements that are more appropriate for others. And the less competition you have, the more you narrow that competition, the more you put different types of requirements that it says what you can and can't offer. That all gets to kind of the notion of serving that average patient as well, rather than kind of the individuals. And so when you're dealing with a population that's particularly vulnerable, that's going to have a wider distribution of issues they need managed, including limited English proficiency, you're setting them up to have kind of that inappropriate care. And over time, we're setting this up to see costs growing faster than they should.
Now, it seemed to me that we'd want to encourage more choice because, well, we want the elderly population and those who are living with chronic illness, we want them to remain as independent as they can be for as long as they can remain independent, living at home or living with a loved one, right, rather than putting them in a nursing home. And I know there's been some polling released recently talking about the challenges of seniors trying to remain independent while living through chronic health challenges. So talk about these numbers and how the CalAIM program changes would make this dilemma even worse.
I think the mention of home health care is something I've actually been really looking into, because it is something where it's a preferred kind of way of receiving care for a lot of people. It actually saves money, but we're continuing to see, and this is the logic of government bureaucracies, we're beginning to see, okay, well, if we squeeze money here, we can create savings. And ultimately what you're doing is something that's penny wise, pound foolish. And also the care is not what people prefer. So I think this idea of kind of empowering home-based care really is something that's very important. And again, this gets into exactly what we were talking about, which is if you're like in Butte County, there's one Medi plan provider. Well, if we don't offer home-based care, you're not going to get home-based care. Or if we offer it under these terms, those are terms you're going to have to accept. So, those are the kind of situations we don't want to put people into. There may be some people that say, look, I don't want home-based care for this reason or that reason. And so there's one plan that would be more appropriate appropriate for when CalAIM continues to tilt the competitive, the landscape and create these competitive obstacles. You're going to be kind of thwarting those options, and so you're going to then be delivering worse care to these individuals, and you're doing that unnecessarily. I think that's something that's really important. And a phrase we use in the paper is that these aren't theoretical competitors, right? These are organizations that are serving this population in the state in 2025, but you're saying, nope, you're not going to expand into these plans here in 2026. And so it's just puzzling because we're not even talking about something that's theoretical. We're talking about CalAIM blocking actual competitors from expanding based on the rules and restrictions that they're creating.
So looking forward, what is the impact of these changes going to be on the new CalAIM patients starting in January, and how are taxpayers going to be impacted by these changes too?
Yeah, I guess if we start with taxpayers, and I think it's important not to kind of be over dramatic. Right? So, in the short term, we're probably not going to see a huge difference, in terms of these costs. And remember, a good bit of this is Medicare spending, so that's a national taxpayer impact, not simply on Californians. But either way, this is not going to be something where you'll point to a chart and say, "Look, there's the spike." But it's something that's going to evolve over time, and that's going to just accelerate those costs over time. And it's one of those kind of slow drip where you don't even notice it, but all of a sudden the budget is just that much more unbalanced because we're not promoting that competition. So it's very much of a kind of slow drip cost on taxpayers. But if you look at all the studies, there's no reason to believe that if we're going to limit competition, that we're going to experience savings on health insurance. It's the exact opposite. We're going to experience accelerated growth in those costs, and that's bad for the taxpayer. With respect to patients, what we know, if you think just logically about it, if we have plans that they're not theoretical competitors, they're actual competitors, which means that these patients are choosing these plans. Presumably, they're choosing these plans because they offer them the combination of services that they value, and so we're denying that to them. So we're denying the preferred choice or the option for the preferred choice. So that's going to have a direct impact on patients where they're not going to be able to get the quality of services that they believe will best fit them. Again, it's not something that in the here and now is dramatic, but it's something that just kind of impacts you over time, especially as some of the things that you're concerned about and the not meeting your specific needs. If that should expand, you're really kind of exposing people to things that ideally they wouldn't have to deal with, whether it's less options to home health care or whatever the case may be. So you're really putting people in a lower quality, kind of less preferred state. And that just builds over time. And it's also a canary in the coal mine in terms of kind of where we're going nationally. And I think that's one of the things that's so powerful about it is that these things, it's the dual eligible population today, but it could be much greater share of the population tomorrow.
We'll get back to our great guest in just a moment. But first, are you following PRI on Facebook? By following PRI at facebook.com/Pacific Research Institute, that's all one word, you'll be the first to read free market ideas from PRI's terrific team of scholars on all the hot issues like education freedom, single-payer healthcare, crime, homelessness, green mandates like the ban on natural gas appliances, and more. Plus, when you follow PRI at facebook.com/Pacific Research Institute, you'll be the first to know when tickets go on sale for PRI's must-attend luncheons, dinners, and galas across the state. And you'll be first in line to secure your spot to hear great speakers like Michael Schellenberger, Gordon Chang, Steve Hilton, and many more. So go to facebook.com/Pacific Research Institute and follow PRI today so you'll be the first to know. So single-payer healthcare, of course, has been on the back burner in Sacramento in recent years. And whoever's elected governor, it's highly unlikely that the Trump administration is ever going to give the green light to California to give them the waivers to truly implement such a healthcare scheme. But it seems like what Cal AIM is trying to do could be a preview of coming attractions in California with other government healthcare programs. So what are your thoughts, and how could what's happening here be the tip of the spear of what we all could experience under single payer health?
Yeah, I mean, that's exactly what I was just talking about. I mean, look, there is undoubtedly a growing push for single payer healthcare, like you said, and that's not just in California, but it's across the US. And if we take an honest look at it, right, the frustration that's driving people towards single payer healthcare is undoubtedly real, right? And that's why you're saying, it's a preview of coming attractions in California, because that frustration is real. But I think, as we've been kind of talking about, the driving philosophy for that push is the misguided notion that single payer healthcare is going to save money. And what's ironic about that is that the problems that are afflicting the U.S. healthcare system, the problems that are creating that frustration, right, the rising costs, the declining quality of care, that's actually being driven by the 50% of the market that's already socialized. I think that's something important we need to recognize when we talk about the U.S. healthcare system. It is not a free market healthcare system, right? About half the patients in this country are covered by Medicare, Medicaid, Veterans Health, and SCHIP. It's the Children's Health Insurance program. So you already have half the market that's socialized, and we're seeing, as the growth of that socialization, we're seeing the growth of these problems. And remember, the other half of the market is burdened with excessive government regulations. And again, we've seen those go up, and we're seeing the problems increase. So we're not only far from a free market healthcare system, but it's the socialization, it's the push, the constant movement toward a single payer healthcare system that's driving that problem. So this idea that reducing competition in healthcare is going to save money, it's just going to kind of create this really unwanted vicious circle that we're in, where we're continuing to reduce competition, we're continuing to grow the socialized or nationalized portions of healthcare, which then create more problems and ironically increase the call for more socialization, greater government involvement. And so we've got to get out of this vicious circle, and kind of competition is kind of a key towards doing that. And if not, you're, the way you put it, the tip of the spear of what we all could experience is just scarily spot on.
So finally, as we close, we know that policymakers in Sacramento and Washington and other states are largely doing the wrong thing here. What should they be doing instead? Share some of your recommendations in the paper for policy reforms in the right direction that would lower costs and also preserve access to care.
Well, if I could wave a magic wand, and this is something you'd have to implement slowly, of course, but if I could wave a magic wand, I would turn all of the government programs into cash-based programs. Basically, what you're trying to do is provide income support. The best way to provide income support is to give cash and start empowering an actual competitive market in both the delivery of healthcare and the delivery of health insurance. Again, really important to distinguish those. And if you made Medicare work like Social Security, that would go a big step toward creating that market. And so, if you're going to say what should we do, I'm going to start with that, because that may be politically unrealistic, and that's putting it lightly. That is what we should be doing. If we kind of what's more realistic in the here and now, well, the first, dealing with these many issue that specifically California needs to remove the restrictions. California needs to make it easier for these organizations and these insurers that are already providing serving this group of individuals. You got to make it easier for them to serve across all of these counties. To say that this county only has one or two insurance choices for this plan is completely unnecessary, and lowering the barriers to encourage that, very, very important. At the federal level, there's all sorts of regulations that punish small providers and encourage consolidation, both of insurers, PBMs, hospitals, of doctors' offices. Why are most doctors' offices connected to hospitals now? Because of the incentives and disincentives that the federal government creates. So we need to go through all of those specific disincentives and remove them. So you're talking about things like, we don't really have time to go into all of them. We could do a podcast on each one, but, a drug discount program for hospitals called 340B. It's being abused, and it incentivizes hospitals to buy up independent practices because you can, in effect, make a lot more money by buying up the practice and making those drugs 340B eligible. Need to address that. Need to address pharmacy benefit managers driving up drug costs. Lots to do there. We need to kind of remove the disincentives that encourage greater and greater hospital consolidation, right? Studies show more competition in hospitals reduces prices. So there's all sorts of kind of disincentives created by the federal government that we can very surgically, pun intended, go after to kind of make the market work better, eliminate the incentives driving consolidation. And that would go a long way towards controlling costs and increasing the cost of care. And I guess I would end with this. There was a testimony that we talked about in the study. And one of the things he said was that the healthcare system will only work as well as the markets that underpin it. And that really stuck with me. I thought that was a really great way of thinking about it. And so what we need to do is incentivize that those competitive markets, remove the obstacles, and rely on innovation and the efficiencies that come from that to drive our need for greater affordability and higher quality healthcare.
Well, let's hope the policymakers listen to you, Wayne. Thanks so much for joining us today and for the discussion on this important issue.
Well, thanks so much for having me. Always great to be here, Tim.
If you like this episode, please tell your friends and subscribe to PRI's podcast at iTunes, Google Play, Stitcher, TuneIn, iHeartRadio, and Spotify. And when you're on these platforms, don't forget to give us a big 5 stars. If you don't subscribe to any of these, you can still listen on PRI's YouTube page, youtube.com/Pacific Research 1. That's the number 1. Thanks for listening. I'm Rowena Ichon. Hope you'll come back again for next round with PRI.